Our next session is to be on innovative technologies, and golly, this isn't just a really exciting time to be practicing spine surgery specifically, and some of the opportunity we have to work with novel materials, to work with novel surgical approaches. I think we've really got a terrific proliferation of options, and how to make decisions on what's appropriate and making value-based decisions on our patterns for adopting new technologies. So again, with regard to disclosures here, I'm going to be speaking on a number of broad spectrum of interbody surfaces, and I've both done some research as well as I've done some consultancy with companies that make everything from 3D printed implants to the HA peak implant to other type of porous implants. So just by way of overview, this section is going to be on innovations in spine surgery. We all recognize that with regard to innovations, there have been various different patterns of adoption, of enthusiasm, and in many cases, abandonment of technologies. And just over the course of recent times, we think about patterns of adoption of lumbar disc arthroplasty, which I think to some extent has not grown, at least to the extent that we might have expected outside of Texas, or some interspinous devices, for example, even to some extent for tibial augmentation or kyphoplasty, interesting innovations that grew quite rapidly, and I think have either plateaued or in some cases really been abandoned. To some extent, when we think about new technologies, and Bill Lavelle brought this up earlier, the idea of looking at an incremental cost effectiveness is what are we paying and what are we getting for what we pay, and is there really some value, is there some improvement if we're going to be paying something extra, are we getting something that's measurable as a result? And the evidence that we look at when we think about new technologies, in some cases, can be compelling evidence. I think in some ways BMP is pretty compelling evidence. Through randomized prospective clinical trials, BMP is as well as autograft as a bone graft material. And that can be quite compelling. Most of the time, though, what we're dealing with is more supportive evidence. So rather than compelling a change in your practice, supporting a change in your practice. And a lot of times that evidence can be based more on preclinical information than on actual clinical rigorous level 1 data. So when we think about novel interbody materials, so much has happened just over the past few years with regard to the development and bringing to market of novel interbody materials. Some of the materials I'll talk about, nanoporous titanium or microporous titanium, both nanoporous and microporous, 3D printed titanium, porous peak, and HA peak composites. When we think about interbody materials, when I started doing spine surgery, I'm looking a little bit to Jeff Decky here. He and I trained similarly at similar times, even though I look older than Jeff. Jeff is a couple years ahead of me in fellowship. But how often did we cut who remembers cutting femoring out, or Mike Legron, right? Who remembers cutting femoring allografts and that breaking when you impacted but I still do use quite a bit of allograft actually in some of my cervical work, but I'm not using that nearly as much as we used to. And we've got a lot of synthetic materials, I think, that perform as well or better. In the realm of titanium materials, there are new porosities that can be created with 3D printing or with subtractive technologies. Acid etching of titanium, some interesting evidence that suggests that the acid etching creating a nanoporosity can actually create a chemical environment that reduces inflammation, reduces fibrinous tissue formation, and is promotive of a osteoinductive environment. PEEK is certainly a material that's been used widely, and I think that whereas smooth traditional PEEK maybe has been problematic with regard to osseointegration, I think some of the new PEEK forms, including PEEK with coating and PEEK composites, porous PEEK, a lot of evidence suggests that modifications of PEEK can really enhance the performance of that as an interbody material while retaining some of the real advantages of radiolucency as well as a modulus that's more similar to bone. Carbon fibers, anybody remember putting in Brannigan cages back years ago. So the Brannigan cages certainly had their own subset of troubles. Mostly breakage was a problem there, and other coatings. It's a really nice review of materials used in orthopedics and osseointegration and interbody implants. A nice review that was published now a few years ago by a number of basic scientists, looking at, in broad categories, titanium and PEEK, and within each of these categories, what surface treatment can do, what treatment with ionization can do, what HA coating, what other coatings can do, what composite materials can do. And this really gets into some of the basic science of how treatment of both PEEK as well as titanium may have a measurable impact on osteointegration and on bioactivization of surfaces. And Bill Walsh from Australia has done a lot of the work that I'll allude to in this talk with regard to some of the animal models, and he was also one of the co-authors on that study reviewing the osteointegrative properties and how treatment of titanium and PEEK may dramatically change how osteointegrated those materials are. When we think about a new technology or interbody technologies, the burden of proof that I think needs to be met for adopting a new technology is number one, we want to show that we can actually improve fusion rates. Ultimately, that's what we're trying to do, is to improve interbody fusion. We want to reduce the amount to which our interbody materials may be subsiding or migrating at all. Fundamentally, we really want to reduce reoperations, and part of that has to do with getting a solid fusion, avoiding reoperations for non-union. Improving clinical outcomes, that's really the end result we're looking for. And also being cost effective, especially in the environment that we just talked about, is certainly quality and safety are number one, but cost has got to go into this. And in the absence of evidence of some incremental benefit of outcome, then it's hard to justify a dramatic difference in cost. So with that being the burden of proof we're looking for interbody materials, let's look at some of these materials and how well do they meet the burden. And in terms of proof, oftentimes, again, what would be really compelling is to say, well, here's a new variant of PEEK that reliably gives us higher fusion rates, that reliably doesn't subside, that reliably never migrates, and results in better outcomes. And in a prospective clinical trial, comparing this to an alternative, we've got level 1 evidence that suggests that this is better. Well, in that instance, that would be compelling evidence, and it would be irrational not to adopt that in the absence of price differences. But in general, we're not going to have that level of evidence. So we're not going to have such a high level of proof. And what we've got to base our decisions upon are supportive evidence, or oftentimes this comes from preclinical studies or a case series. So again, the idea of proof beyond a reasonable doubt versus looking at the preponderance of evidence. Preclinical studies, trying to get direct comparisons of different materials, and again, when it doesn't necessarily exist, through some sort of a comprehensive database with reliable outcomes, oftentimes we'll look at preclinical models. So how do we look at novel interbody materials in preclinical models? Well, one area that I think is quite useful is this study is looking at a metaphyseal model. So metaphyseal bone in general has a greater capacity to heal than certainly epiphyseal or diaphyseal segments. So looking at a femoral metaphyseal model and how well does bone integrate to different materials. And we can look at that both in terms of histomorphometry and the interface between bone and a biomaterial, and trying to avoid a fibrous layer between that bone and biomaterial and actually see direct bone apposition onto the biomaterial. And also another area that's interesting, but maybe not quite as useful, but is a pull-out strength. So how much force does it take to pull a dowel out of a metaphysis? And the idea that there being that if the material is more integrated, then it would take more force to either push it out or pull it out. The trouble there is that metric tends to be more affected by the roughness of the material than necessarily the histomorphometry. But those are models that are certainly interesting to look at in terms of how well do materials integrate. And I'll show you some data from that. Another model, and this is from a paper that I wrote with Christian Putlitz, who did his postdoc in our lab at UCSF, and now he's at Colorado State. But we looked at, in this case, an ovine model for interbody fusion, looking at 3D printed titanium. And essentially what I want to show you here with these fine cut CT scans, or with this histomorphometry, actually these aren't CT scans, I've got CT scans later, but as you see that there's a significant, in smooth peak, significant fibrous tissue around and very little apposition between the bone and the material. And that was also the same with the titanium coated peak. There wasn't really great integration. But having said that, with porous titanium tended to really, bone grew right onto that surface, and the pull-out strength of the material and also the flexion extension rigidity of the material was quite a bit better than smooth peak. Well, how can we modify peak and maybe take advantage of the radiographic properties of peak and at the same time improve the osseointegration? And one of the areas that Innovasis has been a leader on has been the HAP composite material. So this is a composite. It's not a surface treatment of peak, but it's actually a composite that's primarily 80% peak with 20% hydroxyapatite. And this gives us the structural, mechanical, radiographic properties of peak combined with some of the osteoconductive properties of HA. And again, it's not a coating or a laminate that gets scraped out. It's actually integrated into the surface material. And some of the benefits here is that this maintains the modulus is similar to bone. The HA portion allows much more absorption of proteins onto the material compared to regular peak. That tends to be a bit hydrophobic. And there tends to be a better response at the cellular level. So looking at this in terms of histomorphometry, what we see with smooth peak or natural peak is there tends to be that bit of a fibrous layer here. And this is where Barbara Boyan and the group studying nanoporous titanium would suggest or showed that in fact peak opposed to bone leads to a upregulation of some of the inflammatory cytokines, including IL-1, and a downregulation of TGF-beta, and an environment that really promotes fibrous formation rather than bone formation. Whereas when we look at the HA impregnated or HAP composite, the interface between the bone and the biomaterial is a much tighter interface, and the bone actually grows right into the biomaterial. And some talk about whether or not increasing porosity of that surface may actually further increase the osteoconductivity as well as the osteointegrative properties for the material. So this HAP composite has really demonstrated some pretty high-level performance, and some of this research was also done, again, in an ovine model, looking at micro CT scans here, comparing allograft to the HAP composite to natural peak. And basically the HAP composite really did quite a bit better than the natural peak, and similar to allograft with regard to integration of bone, and the apposition of bone to the implant was much better. So the HAP composite is available now in a number of different products, including interbodies for the cervical spine, lumbar spine, and posterior and anterior interbodies. And the imaging capabilities, as you'd imagine, are very similar to regular peaks. You can really see bone formation on plain films as well as CT quite well. Here's a case of mine where I used HAP cases. This is a patient who had prior dynamic stabilization done from L3 to S1, was fused in hypolordosis across the lower lumbar spine, but also some kyphosis across the thoracolumbar junction. And this was a case that I actually revised, and because it was there was no fusion in the back, I guess I don't have the CT scan here, but essentially the facet joints were still wide open. I actually didn't take out those dynamic implants. I went straight to the front, went from L3 to S1 anteriorly with HAP cages, I guess L2 to S1 anteriorly, reestablished the lordosis and got that gap score to change. So I was able to get that lordosis down in the lower lumbar spine and extend the fusion across the thoracolumbar junction. And that went on to a solid fusion. Actually, it was radiographically apparent within 6 months. So there's a registry now that's being put together, and I think this is a terrific service that Innovasis is offering. And it really gives us a great opportunity to audit our own cases. So looking at the registry for both cervical and lumbar, the patient-reported outcomes that are recorded in the registry include ODI scores in the lumbar spine, NDI scores for the cervical spine, and EQ5D, and that allows you to get to what Bill Lavella talked about earlier, to a quality of life score. and also VAS scores for the back, neck, and arm. And just taking a look at this registry, the enrollment has really stepped up just in the past year. Primarily right now, the patients in the registry, there's a bit more cervical cases and lumbar cases. Hopefully that's going to be updated soon because I've got quite a few lumbar to be included in that. But I'm just going to show you some of the, just review some of the preliminary results we've got with regard to this. In the cervical arm, neck disability index, overall a significant improvement of neck disability index scores, reducing by more than 50% at 6 months from preoperative scores. VAS scores also improving, as we'd expect from comparative studies in the literature. And looking at overall satisfaction, the fact that in the cervical arm, all the patients were either satisfied or somewhat satisfied at 6 months after their surgery. And 95% of the patients said that they either definitely or probably have surgery again. In the lumbar study arm, fewer patients, but slightly less reduction, but still 35% improvement of ODI scores compared to pre-op at 6 months. That's very much consistent with what we've seen in some of the other lumbar studies. VAS scores for the back as well as leg improved quite significantly, most dramatically for the leg VAS scores. And with regard to satisfaction with treatment, I thought this was particularly revealing. 94% of patients said that they were either satisfied or somewhat satisfied, and only 6% were either somewhat dissatisfied or dissatisfied with the lumbar surgery. And again, 87% of patients said that they would definitely or probably have lumbar surgery again. So in participating in this registry, how many people have enrolled patients into the HAP registry so far? Yeah, I think we're going to have the ability to really get a lot more data. The geometric rate of rise of enrollment has really been impressive. We'll have access to longitudinal data, comparative studies. I think this is going to be a terrific registry that can be combined with other registries and prospective studies. And I think ultimately it's going to really allow us to develop further information and guide an evidence-based approach to our use of interbody materials. So again, so far, 320 patients enrolled, very good rates of satisfaction in both the cervical and lumbar arm. And then just going back to the overview of new technologies, and I think innovative surfaces are such an exciting area right now with regard to new technologies in orthopedics. And the ideal interbody material is really going to facilitate bone growth, facilitate osteointegration. It's going to image well. Certainly, I've had significant troubles with imaging with a number of the titanium implants that I've used, especially in the cervical spine. We want to limit subsidence, and we want to be cost effective as well. And I think that ultimately, evidence that may compel a change in your practice is really going to require direct comparative studies. And I think that this registry is really going to enable us to do some better work with direct comparisons as well. So with that as an introduction and background, we're going to move into some more clinical talks on interbody materials. And next I'm going to ask Tony Bozier to talk about the role of interbody fusion for degenerative spine pathology. So thanks, Tony.